Hello, good morning, everyone. I'm Philip James, and today's guest is Dr. Larian. Dr. Larian, welcome.
Good morning.
And buenos días a todos que están en este video de América Latina. Buenos días.
Yes.
So we're going to get started. This is a little bit of a different format because we're not going to spend a lot of time this morning, just about 20 minutes or so. But please, for those of you watching, any of your questions in the comments, and they will be addressed either during this episode live or immediately afterwards. Dr. Larian, before we get started, can you please share with those watching a little bit about you?
Yes, of course. So I'm Babak Larian. I'm a head and neck surgeon, otorhinolaryngolo, who practices. I practice in Los Angeles. I'm the chief of the division of otolaryngology head and neck surgery at the Cedars-Sinai Medical Center, and also an associate professor at UCLA Medical Center. I've been practicing in this area for the past 18 years, and the focus of my practice over time has we started doing cancers and tumors in the head and neck area, and now my focus has come down to parotid, parathyroid, and thyroid tumors, so more focused and specialized. And over the years, as I've done this and become more focused, I found that I've become even better at it because I'm repeatedly treating these few diseases.
Your Spanish is pretty good, by the way.
I go on medical missions to Central America, so my medical Spanish is pretty okay.
Yeah, which countries do you visit most often when you go on medical missions?
Yeah, Guatemala most often, and then Ecuador and El Salvador as well.
Okay, very, very interesting. So the topic today, RFA and thyroid nodules, and you look anywhere, the buzz of the profession, it seems right now, anything related to thyroid is RFA.
Right.
How long have you been treating patients with RFA, and what inspired you to start using RFA?
Well, a little bit of a longer story. I started about a year ago in terms of using RFA, but my interest in a less invasive procedure to treat people has been going on for close to 2 decades. Early on in my practice, I really found that the surgeries we were doing for thyroid disease was over-aggressive. And the endocrinologist and I couldn't agree. They usually wanted me to be very, very comprehensive and do total thyroidectomies, where I thought a partial thyroidectomy or a lot less involved procedure would do just as well for the patient with a lot less morbidity, side effects, problems, and so on. And so I was always looking for ways of doing procedures for patients that was less invasive. And so at first it meant that I would do smaller surgeries. And then once RFA came into the picture, it gave me the option of being even less invasive without even having to make an incision and treat patients with smaller diseases or less involved diseases.
So you were already kind of advocating when patients would show up in your office with a thyroid nodule. You were leaning on the side of trying to avoid surgery.
Yes, absolutely.
Impossible.
Yes, absolutely. The advantage that we have is that ultrasound is amazing at showing the thyroid and the anatomy of the thyroid, right? And it's an easy procedure. I do it in my office. Patient comes in, so I can easily monitor nodules with patients and put it on the screen, and we can look at it together and say, look, the nodule hasn't changed in size. We really don't. It's not active. I know it may seem like it's a little bit larger when you look at it on the screen, but it's not bothering you and it's not growing. What would I be doing if I did surgery for you, for example? And so I handheld a lot of patients who had been scared by other doctors through this time, trying to get them to feel comfortable and calm about what they have.
Yeah, because there is some paranoia for a patient that there's probably a process of educating the patient to not be too fearful when there's this bump discovered in their neck or on their thyroid.
Right. Right. Well, you know, the truth of the matter is 70% of women and 50% of men have nodules in their thyroid, right? And
Mhm.
nodules are small growths in the thyroid that some can grow and others can kind of stay steady. And majority of these nodules are not cancers. I'd say more than 90% are benign and may grow and cause problems. The majority don't really do that. They just kind of stay steady and don't cause any harm.
And I guess just to clarify for those listening, that that includes nodules that have cancer, right?
Correct. You know, less than 10% of nodules have cancers in them or are made of
Mhm.
cancers.
You're seeing a number of patients. You've been practicing for many years. What are the like top three questions that patients have about RFA?
Um, the most important question they ask is this an effective treatment, right?
Mm.
Which is the best questions for them to ask, of course. Um, and fortunately, it is. It is a very effective treatment. You know, what you really need to find out first and foremost is if this nodule is benign or not. So you have to have a needle biopsy showing that this is a benign nodule, right? And some people recommend that you do two separate needle biopsies so you have full confirmation that you're dealing with something benign, right? So once you have something that you know is benign and you do RFA, it can really shrink the tumor and oftentimes completely disappear the nodule. It just kind of evaporates and goes away. So it is very effective. The next question is, of course, about pain. Is this a painful procedure, right? Uh, at first, years and years ago, when these procedures started and the people were not very good at doing them, they weren't very good at anesthetizing the patients, right? But now we figured out how to anesthetize the patient in a way that can completely give them full numbness of the area so that the pain is minimized, right? And then the third question is, how long does it take for it to show its effect, right? And so what the RFA does is that it sends an ultra frequency, a high frequency alternating current, right? And at the tip of the probe, in a very small circular area at the tip of the probe, it creates high heat, right? High temperatures, right? And this temperature is what kills the cells that are immediately in that vicinity. And then over time, your immune system comes in and starts eating away at these dead cell components, and then it shrinks. So you don't get an immediate result right away. The shrinkage happens over a few months.
Let's talk about nodules for a moment.
Yes.
Um, just kind of give the overview, just how common nodules are, when to be concerned.
Okay. Well, again, nodules are exceedingly common. 70% of women have nodules in their thyroid when you look at it, and about 50% of men. The reason it's more common in women is obviously because they have a more active hormonal system, because every month they have to prepare their body for creating a life. So that's a very strong system that has to be in place. So the thyroid gland is working even harder for them. And the majority, again, as we said, are benign. And the reason this happens is because the thyroid is so active. When you look at this thyroid under the microscope, it looks like a sponge where there are little gaps in it. And those gaps are areas where they store the thyroid hormones. We call them the colloid lakes, right? They are lakes of hormones inside the thyroid. And the lakes are lined by follicle cells that produce the hormone, right? And so these follicle cells are very active and they're probably constantly regenerating. And in the process of regeneration, at times they form a benign lump, right? That can grow or it can grow to a small size and stay steady. A lot of times the thyroid gets inflamed, right? There's this condition called Hashimoto's thyroiditis where your immune system attacks the thyroid. That can also cause nodules to develop because it's aggravating and irritating this active gland. So those are the main reasons for getting nodules.
And when should a patient be extra concerned about a nodule?
Well, the good thing is that when you do an ultrasound, the ultrasound can categorize your nodule as low risk, intermediate, or high risk. And there's actually clear characteristics that you can see on ultrasound that can kind of alert you of whether this is something to be concerned about or no, this looks very benign and you should just kind of keep an eye on it, right? And and there's clear guidelines for that. So once a nodule hits mild degree of suspicion, right? If you begin to look at it as there's something going on here, then you can do a needle biopsy under ultrasound guidance. So you can clearly see under the ultrasound visualization where the needle is going. So if you have a nodule and the needle comes in, you can see that it's going immediately inside the nodule. And so you can sample the correct area. And then once you have that, you put it under the microscope, and that can help also clarify what you have and what the risk stratification for that particular nodule is.
Yeah, and as we're discussing this, really the underlying discussion is saving the thyroid.
Yes.
And I think it's so important for everyone to be aware that a thyroidectomy comes with risk. Can you kind of explain briefly the risks of removing the thyroid, and secondly, long-term implications once the thyroid has been removed?
Okay, sure, absolutely. Well, the thyroid gland obviously produces hormones that help control your metabolism, right? And your brain detects the amount of hormone in the bloodstream, and based on the level of hormone, it sends a stimulating hormone to the thyroid that stimulates the thyroid to produce its hormone. So it's a feedback loop, and the brain is involved in that feedback loop. It's directly controlling the functionality. So the brain detects what the level of metabolism in your body is, that demands the functionality, and adjusts the amount of thyroid hormone being produced, right? And so if you don't have your thyroid, you're not able to adjust. You take a pill, right? But that pill doesn't have the ability to make adjustments as you go through life. You become less active or more active, right? So not having your thyroid means your metabolism is a constant without variability, which our body constantly goes through variability. So that's one downside, right? You lose that flexibility. Next, the anatomy of the surrounding structure. So the thyroid has multiple blood vessels coming from the top and the bottom, feeding it, right? So when you do surgery, you have to disconnect these blood vessels, so there's a risk of bleeding. Fortunately, because we've gotten better at doing the surgery, that risk is very low, right? It's significantly less than 1%, but it is a risk. Now, behind the thyroid gland, there are two very important structures. One is the vocal cord nerve, also called the recurrent laryngeal nerve, that comes out of the brain, goes into the chest, does a turn, goes behind the thyroid, and goes into your voice box, which is right here, okay? When you have one on each side. So you have to find that nerve during surgery and protect it. So there is a risk to that nerve, right? Which would, if it is affected, then the person would become hoarse when they spoke. Then there's also the parathyroid gland. The parathyroid gland is a tiny gland the size of a grain of rice that controls the level of calcium in your bloodstream. You have 4 of these parathyroid glands. You need only one of the 4 to function to be totally normal. But if you have a thyroid that's inflamed, that is enlarged because of a goiter or a nodule, that parathyroid gland may be squished. And more importantly, its blood vessels may be kind of stretched out. So it may be more easily harmed when you're doing surgery. So these are the 2 other major complications that can occur with surgery is vocal cord nerve injury and paralysis, and parathyroid malfunction, right? So the vocal cord nerve injury can be corrected by injecting material in the vocal cord or repositioning the vocal cord, which can, recreate your normal speaking voice, but not singing voice. And the parathyroid, if it's completely done and not functional, you'll have to take large doses of calcium and vitamin D to supplement for it. So you can overcome these issues, but obviously not ideal at all.
Yeah, and I really think it's so important to emphasize this. I mean, I had a thyroidectomy, and all the dangers that you just described happened to me: the parathyroid damage and the severed laryngeal nerve and vocal cord paralysis. And so I think it's important to set the stage for patients who have not had a thyroidectomy yet, just how significant it is that a procedure of addressing a thyroid nodule without doing a thyroidectomy is really a big deal.
Yes, of course. I think as doctors and surgeons, we were always doing radical procedures. Poor women were having radical mastectomies for breast cancer, and now a lumpectomy does the job, right? So now that we've understood the disease better, we are understanding what the pathology is, we're addressing it appropriately, more appropriately, I'd say. Rather than being radical, we're being very specific. And that's really what RFA is offering you. It's very specific, less invasive way of treating a nodule rather than a radical total thyroidectomy.
Can RFA be used for nodules that are not benign?
There are some places that are using it to address some of these things, and I think in
Mhm.
time they will be. But part of the problem is that when you have a cancer, you don't know the degree of aggressiveness of that cancer. Now, I think in time, as we become more aware of the genetics, so when you do a needle biopsy and you find, okay, the genetics of this particular cancer is
Mhm.
not very aggressive, then RFA is very appropriate. And then when you find something that, oh yeah, the genetics is this is very aggressive, it tends to want to spread to lymph nodes and other parts, doing an RFA is not going to encompass the whole thing. So I think the challenge is finding the genetics, the appropriate genetics to direct you as to whether RFA is appropriate or not. And we're getting there.
You're talking about how these advances in innovation and technology, it really accelerated in the last 12 to 18 months.
Yes. I
And
think genetics
you,
has really made huge leaps and bounds.
while how many thyroids maybe were saved during the pandemic because so many surgeries were postponed, and during that time there was advances in RFA and molecular profiling, maybe some surgeries were avoided.
Yes, absolutely. I mean, the field is progressing. So every year when I go to the thyroid conferences, I'm amazed about how much more I'd say we've intellectualized the process, and we're
Mhm.
analyzing patients and trying to treat them with less aggressive measures.
Yeah, it's great news.
Yeah.
Real quick, it looks like we have people tuning in from Colombia and Honduras. Just a quick hello to all of you. And for the rest of you who are tuned in, we see a number of questions. I'm going to flash some of those questions on the screen now just to know you are being acknowledged. But because this is a fast paced interview with Dr. Larian, he will probably be addressing these questions directly after this session. But we see you there. We see your questions. Dr. Larian,
Yes.
um, what should every patient, every thyroid nodule patient know about RFA?
It is a very good option they should entertain. First and foremost, they should always think about it as an option, especially if they have a nodule. There's a needle biopsy done that shows that the nodule is benign, and they're being offered a surgery. This is an alternative they should definitely consider because it can be effective. You don't have a cancer that's life-threatening. You're only addressing a nodule because of the size, put the potential for it to get larger, or the potential for it to push on the surrounding structure, all issues that RFA can address.
Um, what should every doctor know about RFA?
They also need to learn that this is truly an option. And I think that's the problem. Educating the primary doctors, the first line of defense for patients, which is their primary physician that sees them. If they become aware that this option exists, then they're not going to let nodules get large and problematic, and also let the patients know who have a lot of anxiety and fear about surgery, right? That there's a less invasive option that they could entertain.
Mhm. Dr. Larian, as we get close to the end here, any final thoughts or any final words you'd like to share with those watching?
Yes. Uh, there's a lot of information about thyroid nodules and how to treat it. I think it's best that you educate yourself before you go see your physicians so that you can ask them questions. I know a lot of doctors hate Dr. Google. And when a patient comes in with a whole list of questions, they get upset. But most of us actually appreciate an educated patient. We may have to retrain some of the things and correct some of the information, but at least we have a basis to talk about. So if you come in with some degree of information, we can have a more meaningful conversation in one session rather than dividing it up into multiple sessions.
if a patient wants to learn more, or even a doctor would like to learn more about RFA, where would you send them?
Actually, on my own website, I have pages on thyroid nodules, thyroid cancer, goiters, as well as RFA. So if they log on to larianmd.com, there'll be information on there for them.
Yeah, your website's a great resource, and that link will be included in the notes to this episode. And for those of you that are watching it and want to hear or listen to this again, it will be also on the Dr. Thyroid podcast. Dr. Larian, one more question for you. Your office is in Beverly Hills. If you were driving down the road near your office and there was a big billboard up about RFA, what would the billboard say?
A fantastic option that is less invasive and could avoid all sorts of complications.
Sign me up for that one.
Yes.
I will take that every time over having a surgery that could have some risks to it.
Absolutely. I have to say your voice is fantastic, considering that you had that complication. I'm very happy to hear it.
So it was difficult before getting a vocal cord implant. So
yes,
the vocal cord implant helps, at least speaking, but then of course there's less airflow. So it makes it difficult to do any heavy exercise, but I'll take the voice.
Right, of course. I understand.
Yeah. So it looks like we're just about out of time, but Dr. Larian, will you be able to review? We have a number of questions that were asked. Review these questions and respond in the Facebook comments.
I'd be happy to.
Yeah, so everyone, Dr. Larian will address your questions. We see you there. And again, this video will be available on YouTube, Facebook, and you can also listen to the Dr. Thyroid podcast and listen to the episode there. So thank you all for joining us. Dr. Larian, thank you so much.
It's a real pleasure.